everyone. This is the third session in the early orthodontic treatment series, and in the past we've looked at habits and we've looked at development of the palate, essentially related to class 1 and class 2 imbalances. Tonight I want to talk about the class 3 problems, and I think if any malocclusion needs urgent treatment, it's the class 3 jaw. And I'm making that point because if you understand growth and development of the facial skeleton, you will realize that babies are born class 2. They have to be class 2 because the retrognathic mandible is designed for breastfeeding. So it's normal for a baby to be class 2 with normal breastfeeding, as we've talked about before, normal nasal breathing. The upper arch develops and the mandible grows downward and forward. When you have a young child, even as young as 5 or 6, that has a class 1 jaw pattern, that's actually telling you that they're an underlying skeletal 3 jaw because the mandible is already well ahead of its growth potential. So what I'm saying is you have 2 6-year-old patients. One presents class 2, they're a normal patient. The other one presents ideally class 1 or even worse still class 3. They're not going to grow into a class 1 patient because they're already 2 to 3 standard deviations from normal. So in my I'm trying to minimize the screen stuff I can see down here. Why that's not moving. So in my presentation tonight, I'm going to first of all clarify which class 3 individuals require early treatment and which ones really wouldn't benefit from that by subdividing a class 3 bite into a maxillary deficiency problem and an increased mandibular length problem. And the bottom line is if someone has an increased mandibular length and doesn't have a postural crossbite, there's not a lot you can do early. But the cases that you do need to treat early are 2 categories, which I'll discuss tonight. Category 1 is what's called a postural class 3, or also known in the literature as a pseudo class 3. And that's a patient that actually you can bring the mandible back to edge to edge, but there's something that's causing them to push their jaw forward, and that normally is a crossbite associated with anterior teeth. So that patient definitely needs early treatment because if you don't correct the functional shift related to the anterior crossbite, that will stimulate increased changes in mandibular length and position, which will make it harder to treat later. And the other patient is the class 3 mid-face deficient individual that has a normal mandibular length, normal mandibular position, but the maxilla is underdeveloped and or retrognathic. And those patients need treatment that will not only develop the upper jaw, as we've discussed in earlier seminars, but would also require what's called reverse pull face mask therapy. And that's not to be confused with headgear. The term headgear, as we discussed in seminar 1, is not really used these days because we don't want to hold up growth of our upper jaw. We don't want to distalize based on facial profile other than in very rare occasions. But a reverse pull face mask is an external device, and we'll look at some today, that's actually designed to do the opposite, to protract the maxilla forward, to correct this maxillary deficiency in that individual. Now, again, any questions you may have or cases you'd like to show me, you can just fire me an email, and I've left the email up there for you. Secondly, I have had a lot of people from previous seminars that wanted a copy of the slides, and again, I'm happy to send you those via a zip file, so you can just do that by sending me an email. And then what we're tending to do with these seminars, we are posting some from up after the seminar in an edited form on my Facebook page with a link back to EDEN and through YouTube for people who may enjoy this seminar but like to watch it again, or have friends they think would benefit from viewing it again. So let's start with young Lucy. And Lucy is 8 years old, and she is a pseudo class 3 or postural class 3. So you can get her lower jaw and bring it back edge to edge, but in this situation, in her habit bite with her back teeth together, she actually has a negative overjet. And a lot of this information I'm going to present tonight comes from the research of an orthodontist from the UK by the name of Dr. John New. And John New has a whole new thought process on the development of a malocclusion. He calls it orthotropics, and it's all designed or all discusses position of the tongue, breathing through the nose, position of maxilla, and posture is the main cause. And there's a lot of merit in what he says, particularly in some of these class 3 individuals that have a postural imbalance to their jaw. And if you look at Lucy when she was younger, you can see at age 2, and then at 4, and at 6, and at 8, she already has that postural class 3 imbalance. And so the question is, if she was treated early and her tongue posture and her crossbite was eliminated, would that in fact change the direction of growth of her jaw, or is she doomed to be a class 3 surgical case? And I think that's the million-dollar question in orthodontics. So when I have a young child, and I normally encourage children who are class 3 to be sent in early mixed dentition, sometimes late deciduous. And the reason I do that is because I want to see what component of this problem is maxillary or mandibular. And if it's maxillary, clearly I treat early. I also want to see if there's a postural component, because the earlier you correct the postural imbalance, the better chance of tongue muscle function returning to normal and normal maxillary growth occurring. The longer you leave it, such as in Lucy's case, obviously the harder it's going to be treat. So Lucy's treatment, because it was picked up later than normal, involved expansion of the upper jaw in conjunction with changing tongue posture. And if you now look at the profile on the bite, and this is without any fixed braces, Dr. Mew uses a technique where with a series of removable appliances called bioblocks, and in conjunction with reversible face masks, he is able to develop the upper jaw to its maximum size and then protract it to its correct spatial relationship to the lower jaw and to the cranial base. And this is a case in point of a class 3 malocclusion that is treated non-surgically and without emphasis regarding to posture. And here we have Renata, who again from a very early age adopts this posture. And when you see young children with this sort of underbite, remember they are very much away from a normal bite for that age. A normal bite at that age is class 2. So what are some of the things that may cause this bite in young children? Most common is a tongue tie, and we've discussed that earlier in its diagnosis and early treatment. And that's causing the tongue to be in a lowered position, so the maxilla doesn't get its development, but it's actually pushing the mandible forward. Second is the crossbite, and deciduous teeth even, causing the patient to hit and slide the jaw forward. And the third, with research from Japan, relates very much to very large tonsils. We talked about the long faces and the adenoidal problems in previous seminars. One thing we see sometimes in postural class 3s is very large tonsils almost touching each other, what we call grade 4 tonsils. And because of that, the patient wants to posture their jaw forward to open up their airway. If you have a sore throat, you know how comfortable it is to constantly swallow. You want to almost have a lowered position of the tongue. And that's what happens and encourages this muscle imbalance, which we'll look at later with some of the research by Dr. Rob Frankel. And looking at all these children, when I get a class 3 patient, I ask the parents to bring in photos of the kid from an early age. Normally they're school photos, sometimes they're even preschool photos such as this, and it's amazing how you can see when this postural change actually started. So if we look at Lucinda, she's in a mixed dentition. She has a class 3 maxillary deficiency problem. So what that means is she does not have an increased mandibular length, because if she did and had a normal maxilla, there's not a lot we can do. So remember, if you have a young child and they present you with a anterior crossbite, first thing you should do is see if you can get their jaw back edge to edge. And if you can, there's a good chance of early treatment because it's postural in component. If you can't and you order a lateral sephometric radiograph, you look at maxillary position. And if the maxilla is deficient and retrognathic, such it is here in Lucinda's case, then you do want to treat early by expanding the upper jaw and using a face mask to bring it forward. But if the maxilla is in a normal position, normal size, and you have this big mandible, which is normally of genetic origin, then really, unfortunately, that patient is heading towards a surgical outcome. So if I can reframe that by, or reword that by saying, that doesn't mean that every kid who's 9-year-old with a big mandible is going to need surgery. That's what we're trying to avoid. What I'm saying is if there's no postural imbalance and there's no maxillary deficiency and there's a genetic history of big mandibles, then there's not a lot you can do to stop that mandible growing. And chin cups and face masks for the mandible don't actually prevent it growing. What they do is rotate it backward, but the mandibular length effectively continues to increase. So I say to parents, I'm sorry, Mrs. Jones, now that I've taken full records and I realize your problem's related to the lower jaw, you can look forward, unfortunately, to having an operation on that jaw when your child is 18, 19, as the case may be. But the research by Moyers and McNamara have shown that probably 80% of class 3 malocclusions are not increased mandibular lengths. In other words, 8 out of 10 kids who present with this sort of bite would benefit from early treatment because they're postural and or maxillary related problems. And that's important to note because I do get second opinions where a child presents with an underbite, been told by the previous clinician, nothing we can do, you need surgery. And I ask the parent, well, was there any records taken, was there any diagnosis? And they say, no, just a look in the mouth and told problem is related to the lower jaw. So really, without records, you've got an 80% chance of being wrong, and unfortunately, you're heading that child towards an unnecessary surgery if the diagnosis is incorrect. So in Lucinda's case, she's initially got a reverse overjet, 3 millimeters, and she's had expansion of the upper jaw with reversible face masks using orthopedic forces. So to move teeth, we use forces 30-40 grams by tipping, maybe 120 grams bodily movement. But when we're moving bone, in this case the maxilla, in a forward position, we're using a face mask. And that is orthopedic force, which is measured at 800 grams, nearly a kilogram of force. Now this is the older headgears. This is called the Hickam face mask. And this face mask puts pressure not on the condyle, so it doesn't increase the chance of TMD. It puts the force to the gonial angle of the mandible, which is the thick bone of the mandible, and that absorbs the force, so you actually are not getting forces on the TMJ. Many people who use chin cups and the vector of force is at 45 degrees to the chin, they run the risk of causing joint dysfunction within the patient. And so what this child is using is the mandible as an anchor with elastics to a intraoral maxillary appliance that is not only developing the upper jaw, but is also protracting that upper jaw forward. And if you look at this girl with good headgear usage, and you look at her before and after treatment photographs, and one thing Dr. Mew stresses is take the photos with the child looking at their own eyes in the mirror to get the normal Frankfurt horizontal, the normal head posture, and then take it with a ruler with the child the same distance from that ruler. So you can always then one-on-one superimpose the before and after photographs. And if you look at the measurements of this girl before and after, you can see she's had an amazing forward growth of that maxilla that's greatly helped that class 3 problem and reduce the percentage need for orthodontic surgery. And this is why it's so important that if you've got friends and relatives that are young with this class 3 jaw, they go to an orthodontist very early. I can't stress that enough. Just talking about face masks, I mean, the Hickam bow is something that we use in our practice for many years, and of course it's quite cumbersome, and it's not the sort of thing that a child likes wearing with their friends at home. Most face masks are worn at home and at night, so it means the kids should really put the face mask on when they come back from school, take it off for dinner and brushing their teeth, back on till the following morning. This new bow, which was described in the literature as the Tandem appliance, I'll just go through this. So in the upper jaw, maxillary deficient patient, we're talking about a class 3 individual that has a maxilla that's retrognathic and or underdeveloped. We have a maxillary expansion appliance, and we've talked about that in course 1. Attached to that appliance are hooks, which are near the center of resistance of the maxilla, center of rotation of the maxilla, round about between the canine and premolar, about 2/3 up the root surface. And in the lower, you have an anchor device, which does nothing more than allow a child to place this little bow, this Tandem bow, into the lower jaw. So that's the equivalent of the Hickam chin cup. But this appliance does not have a chin cup, which makes it very user-friendly. So in my practice now, when I have a maxillary deficient patient that is class 3, then I get in during maximum growth of the maxilla, which is between stage CVM on the vertebrae 1 and 3. And I use an expansion device with semi-rapid expansion and a reverse pull face mask. So what you're looking at on this screen is the expander. What you're looking at here is the anchor unit in the lower. And what these metal clasps are is to place the bow, the Tandem bow, and the Tandem bow has hooks on it for elastics. So when you look at this, you can see how easy it is for children to wear, much more comfortable than the Hickam appliance. And traditionally we use the face mask called a Delaire face mask or a petite face mask. And these things are almost something out of a Hannibal Lecter movie where you've got a chin cup, you've got a forehead cup, you've got this bulky thing over the cheekbones, and it really looks like a full mask. Obviously children tend not to wear that as directed, whereas this Tandem bow is very, very easy for a child to wear and actually not that obtrusive. So they can sleep with this, they can watch TV with this, and I've even had some kids that are quite happy to wear it to school. The best clinical description of this Tandem bow, I think, would be by an orthodontist in the States, Leon Klempner, and he published this in the Journal of Clinical Orthodontics in April 2003, and he talks about which cases you'd use it for, how you construct it, how you fit it, how you adjust it. Very good summary article. And so looking at this child, same problem. Katerina here is, again, have a class 3 jaw pattern, but the class 3 jaw pattern where the maxilla is retrognathic. And again, using a semi-rapid expansion with a reverse fill face mask, you can see the tremendous change. But that's only half the battle. Once you've developed the upper jaw, brought it forward, you've got to change the tongue position. And that's not the time to find out the child can't breathe through the nose or that they're tongue-tied, etc., etc. So again, going back to basic principles, child comes in, should have an airway evaluation, should check their tongue posture, and remove all those unwanted myofunctional problems before you start your orthopedics. So by the time you finish your face mask work and your orthopedic expansion, you can then train the child to get their tongue up on the palate, which is where it should be, which will maintain your expansion and keep those teeth forward. If the child reverts back to a lower tongue position, you're going to get a high relapse tendency. And all these children, similar treatment plans, no fixed braces in any of these cases. These cases are all treated with the new technique of a stage 1 upper arch expansion appliance reversible face mask therapy, and then a retainer. And the retainer that I like to use is called a modified Frankel 3, and I'll show you one of those in a moment. So with these class 3 patients, the objective is check the tongue posture, develop the upper jaw, bring it forward, encourage the tongue to then sit in the upper jaw, and then hold in that position with nasal breathing until the deciduous teeth exfoliate, adult teeth come through. And you can see in Karen's case the change in her facial balance. It might look as though she's class 2, but if you look at the diagram, you can see she's got actually a postural class 3 problem associated with that in-standing upper right lateral incisor. Here we have a patient who has good muscle tone and has been treated just by tipping the upper incisors forward. And the problem here is when you just tip the teeth and you don't do any orthopedics or you don't change tongue posture, you are going to get a high chance of orthopedic relapse, such as happened in this chap's case from the age of 11 to 12. So when this chap presented at 12 and a half, you can see he has classical maxillary deficiency, which you can pick up cephalometrically. We've discussed the Jefferson analysis and how easy it is to predict a maxillary deficient class 3 problem. But also, just look at the sclera of the child's eye, and that gives a dead giveaway of a deficient maxillary position. John Mew also uses an indicator line. It's called the Mew indicator. It comes from the tip of the nose to the upper incisor, and that indicator line should be a certain age, a certain size for a certain age, and the more deficient the maxilla, the more increased that measurement is. So in this chap's case, his indicator line was 7 millimeters larger than it should have been. So that tells us that we have maxillary deficiency. And his treatment, semi-rapid expansion, an older reversible face mask, and this shows you this Hickam chin cup, which gives us what we call intermaxillary orthopedic traction. And please understand that this device hinges at the condyle without a reverse pull system. So that really reduces the tendency of pushing the chin downward and backward, as would a chin cup, as would a Dallaire face mask, as would a petite face mask. All those lengthen the face, and what we want for a good-looking face is forward growth and a reduction in the lower anterior face height for these long face class 3 individuals. So looking at the forces here, you can see the reciprocal action, but you can see no rotational backward forces as you would with the traditional face mask. Now, the only benefit of the tandem bow mask is it's not as bulky, but the forces and the orthopedic effect is identical. So there's nothing wrong with using this, but I just find I get better compliance with a more modern tandem bow. And again, going back to the patient with the class 3 lowered tongue position, edge-to-edge bite, and now showing with that face mask and that arch development, gone from a negative overjet to an actual positive overjet, and definitely forward position of the maxilla. You can see the sclera of the eye, and you can see the improvement in that mid-face. Also, without any fixed braces, more because of the lip posture and the action of mentalis, you can see the uprighting of those lower incisors. And if we superimpose sephometrically or on our photographs, we can see that A-point position of maxilla has moved forward, and at the same time we've had some forward movement of the lower incisors. So that uprighting of the lower incisors, you'd worry that would push the kid back into crossbite, but if you bring the maxilla to where it should be, you can actually see the result. And this is the same child, 12 years out of treatment, no fixed appliance therapy here, just orthopedics. And you know, the biggest awakening I ever had in my orthodontic career is when I visited the Frankel practice in East Germany to realize that Frankel, much like John New, much like the purists in functional orthopedics, actually get in early with appliances that are muscle-borne, that change muscle posture, so that you get better growth and development, and the teeth have a better chance of coming through in the correct position, as opposed to sort of traditional orthodontics, which is to wait until the adult teeth have erupted and then try and pick up the pieces. It's a whole new paradigm shift in the way of thinking. And we'll show you lots of these cases. This little chap, again, anterior crossbite, postural class 3, maxillary deficient. So 2 indications for early treatment: undeveloped upper jaw, retrognathic maxilla, and anterior crossbite associated with the teeth. So using semi-rapid expansion, and rather than a face mask, because it's not as severe here, using what's called a vestibular appliance. And a Frankel appliance is a vestibular appliance. It's an appliance that keeps the cheeks away so that the tongue can hit up on the palate, and it's an appliance that keeps the upper lip away so it doesn't have a restraining effect on that forward growth of the maxilla. We'll look at some of those appliances in a moment. Now people ask me, well, how early do you treat a class 3? And I always say, well, it depends on what the problem is. If it's big mandible, normal maxilla, you don't treat early. If it's maxillary deficiency, you do, and you tend to treat that in a mixed dentition during maximum growth of the maxilla. But if it's postural, then I want to treat it as soon as the kid's sent to me. And I'm going to show you a case now of a 5-year-old that has a postural functional shift of the mandible and why it is treated early and what we use to treat it early. And I'd like you, in Seminar 2, I referenced the work of Dr. Herman Ramirez, who did his PhD in the University of Queensland, did his initial dental training in Columbia, and is now a specialist orthodontist in the Faculty of Dentistry, University of Manitoba in Canada. And he published in the Journal of Clinical Orthodontics in 2003 a technique that was passed on to him by a Professor Pedro Planas of Spain. And this is a technique where you can use it in children who still have deciduous teeth but have a postural imbalance. And you're basically putting composite resin on the deciduous molars to change the bite such that you encourage normal tongue position and normal forward growth. So let's look at that. Obviously, this is a technique that I can give you a lot more information, and one of the frustrations I have is when I have a young child that comes in that has a postural class 3 imbalance, and I send them back to the general dentist saying, listen, eliminate the crossbite, do some resin buildups. Many people have never heard of this technique, and so I send them the article that I'm referring to in JCO. They follow that, and they always ring me back, months later, years later, say it was such an easy thing to do, and it had such a good long-term effect on the patient. Now, Professor Planas did these in little 5- and 6-year-olds directly in the chair. My advice to you, it's very hard to get the accurate build-up and the correct angle for posture by doing it freehand. So I'm going to teach you or show you an indirect technique. So this is the little chap. She is 4.5 and presents with this complete anterior crossbite. And all of you will see one of these patients in your lifetime in practice, and when the parent says to you, and many parents probably aren't even aware of this, but they start getting aware when they see that kid's jaw getting bigger and bigger. But it's obvious to most people that having this sort of bulldog bite is not normal. And so many parents come to the dentist and they say, well, what do you do here? And the dentist scratches their head and says, well, still deciduous dentition, too young to send to the orthodontist. I think we just monitor this. Now, monitoring it is like watching grass grow. It's not going to get better on its own. If anything, it's going to stimulate increased growth of the mandible, which will result in surgery long term. So what I do here, confirm it's postural, get the mandible, make sure I can slide it back edge to edge, which we can. Then we take upper and lower impressions, and we build up on an articulator a resin core on the first and second deciduous molar. So here's the upper build-up, and what you see in blue there is again to some triad gel so that when the vacuum tray is formed, you won't get it sticky in the undercut. Why are we making a vacuum retainer here? Just to make it easier to transfer the anatomy of the build-up straight into the mouth. This is why it's called a indirect technique. And same in the lower. And if you look closely at the angle of those build-ups, you can see that there's been two things. In the mouth, there's going to be selective grinding on the cuspids to increase the mesial facet of the cusp to prevent that hit and slide forward, and that allows better lateral excursion when you reposition the mandible. The second thing is you can see the angulation of the, or inclination, sorry, of those tracks on the upper and lower deciduous molars. So if it's a posterior crossbite, you'll get that inclined plane contoured from the lingual to the buccal on the lowest deciduous molar on the side of crossbite only. But for class 3 kids, such as the one I've shown you, in other words anterior crossbite, the inclined plane is contoured from the distal to the mesial on the lower deciduous molars on both sides. So that way when the patient hits, they're not going to hit and slide their mandible forward. In fact, all the force is put through the maxilla, preventing that anterior crossbite. So I try this in the mouth, make sure it's fitting accurately, and this is the vacuum formed retainers that have been formed in the lab over those resin buildups. And all you do on your articulator is open the pin till you clear the crossbite. Then chair side, you put resin inside the suck down retainer, you etch the deciduous teeth, and then you place that suck down retainer with the uncured resin over the teeth and light cure. And as a result, you get a very accurate inclination and build-up. And showing you here, this is that same child with the planus indirect tract composite build-ups. Child goes from having a anterior crossbite to now not being able to hit and slide because the point of anterior crossbite has been eliminated. And this is the important time where you've got to start changing the tongue position. So if you look at this kid, you can see the tongue is still in that lowered position. Wrong posture for class 3. We've got to get the tongue out of the mandible up on the maxilla. And in that regard, we use various myofunctional exercises and what's called a class 3 myofunctional trainer. The class 3 myofunctional trainer prevents the tongue from posturing downward at night. The exercises during the day promote the tip of the tongue hitting the palatine rugae behind the upper incisors, contributing to their development and tipping forward of the teeth. And you leave these direct tracks in until you get the eruption of the adult incisors. And you know, every time you see these diastenas appear between the deciduous teeth, that's like money in the bank, because you know that a deciduous incisor is going to be a lot smaller than the adult incisor. So if you have a young child that already has crowding or crossover of deciduous incisors, there's no way you're going to have spontaneous growth and development for the eruption of the permanent teeth without crowding. So looking at what's happening here, you see that that crossbite has stayed eliminated right up until the eruption of the first permanent molar. And at that stage, you can eliminate the buildups if they're still present. And then you just sort of give the child a holding appliance, and that is what I was referring to as a vestibular appliance. The one I use is a modified Frankel, which we'll look at towards the end of this seminar. And the child wears this at home at night, changes tongue position. We monitor that there's no more anterior crossbite. We monitor their breathing through their nose. We monitor that their tongue is up on the palate, and you'll see how this keeps the stability for our corrections. So again, here's a young patient. He is just turned 5. He's sent to me by his referring dentist who understands the benefits of early treatment for class 3 jaws. I take one look at this chap, I elicit a family history, realise there's no genetic tendency of class 3. I get the mandible and I relax it, get the kid to open and close a few times. I slowly drop the mandible back, and lo and behold, I can get that jaw back to edge. So I know that's a postural 3, and as a result, I want to treat it early. So build-ups are placed on the back deciduous molars using the Planus technique, and then the child is given, back then, we didn't have a class 3 trainer, so we used the normal myofunctional trainer, and we cut the labial bow away so it wouldn't have any restraining effect on those upper teeth. And the child would then wear this at night, maybe 1 hour during the day, to change their oral posture from being downward to being upward. So the tongue is working with us to keep that maxilla the right width and push that premaxilla forward with growth. And just that simple little bit of treatment with resin buildups and a trainer, you can see the tremendous change in this patient's bite that would have not spontaneously occurred had no early orthodontic treatment started, commenced. So the concept is the build-ups are left in place until the eruption of the first permanent molar, and that effectively establishes the right vertical, and then you monitor the kid with a nighttime retainer until the eruption of the full maxillary incisors to confirm that those incisors do actually get pushed over the crossbite. And this is where a little technique called the paddle pop technique comes in well. So remember where we are. We've got a postural class 3 patient. We have built up the deciduous molars to eliminate that crossbite. We've changed tongue posture. And now I get the kid during the day, whenever they remember, to use a paddle pop stick and basically to put that paddle pop stick behind the upper incisor and bite on it. And what that does is that pushes the forces towards the upper incisors, almost like sucking your thumb, and you want this sort of force in a class 3 mid-face deficient kid because you want those upper incisors to actually push over the lowers. So I've talked a bit about early treatment, but one of the biggest problems in early class 3 correction is maintaining that correction as the child continues to grow. So I'm monitoring these kids on a 6-monthly basis, confirming their tongue posture and their nasal breathing, and the compliance of wear of the retainers is all good. There's 3 retainers, and I'll leave it to you which one you want to use. Chris Farrell has designed an appliance with the MRC group called an NRC IC3, which is an inner core. I'll show you one of those in a moment. Dr. Yani Sawa in Japan has developed a YC3, very similar principle, but a more rigid appliance. Or you can get the customized appliance, and the thing there is more comfortable for the kid, but of course, because one size doesn't fit all, you're paying quite an elaborate laboratory fee to make that modified frame. This Farrell's design, this is called an IC3 trainer. The C stands for the dark inner core. And this is a very effective appliance for you to give to a class 3 kid who's got a postural jaw problem to start changing the tongue posture. And you can see that's where the tip of the tongue would now rest. This is the appliance developed in Japan, Dr. Yani Sawa, and it's called a YC3, named after him. And basically it's a removable functional appliance which is especially designed to intercept and correct class 3 postural malocclusions in the primary dentition. So you don't need an impression for this, unlike a Frankel. It's very easy to insert, and there's minimal sort of adjustments associated with it. Appliance works, and the same way the Frankel works. You've got 3 elements. You've got a maxillary labial shield that prevents that upper lip from restraining forward growth of the maxilla and doesn't prevent the upper anterior teeth from being pushed over the crossbite. It's got a splint effect, so you've got that sliding ability of maxilla over mandible. And then you've got a lingual guide where the tongue is not allowed to sit in the lowered position. The tongue in a comfortable position will then be shoved up on the palate, and that, without the kid knowing it, is the correct position to stimulate that forward growth of the maxilla. So lingual guide, lifting and positioning the tongue in the right spot. The splint, removing the occlusal interferences and correcting the occlusal plane. And then, of course, the whole buccal arrangement, you'll see here with my arrow, that promotes adequate forward growth and development of the maxilla. And this comes from the article, and I'll give you the correct spelling. It's Dr. Yani Sawa, Y-A-N-A-G-I-S-A-W-A. At the end of this presentation, I'll give you the references, and that's one of the big ones. And you can see, going back a slide, this labial shield effect, this splinting effect, and this lingual guide. Labial shield is the pink here, the splinting effect, maxilla to mandible, is the yellow, and the lingual guide, as you can see, prevents the tongue from dropping down on those lower incisors. The tongue is forced up onto the maxilla, which is where it should lie. So you can adjust these appliances to make them comfortable for the patient, a bit like you can a trainer, because the silicone that it's made of is easy to trim and adjust. If you look at this little kid, and most people think you're crazy treating a 3-year-old. I don't think I'm crazy at all, because if I have a postural shift, I know that's not going to get better at 4 or 5 or 6 or 7. So what I'm doing is a combination of some resin buildups to eliminate the crossbite, with the child wearing either an IC3 or a YC3, and you can see that you just want to eliminate the postural imbalance of that lower jaw to give that kid the best chance of having further future forward growth that's not going to cause worsening of the class 3, and hence is reducing the need for major orthodontic surgery at a later age. And this kid's just worn that appliance for less than a year here. Again, another child opening the vertical, changing tongue posture. Now, for these appliances to work, the IC3, the IY3, all of these appliances have one thing in common, and that is the child has to breathe through the nose for them to be effective. If you have a mouth breather, you're going to have a child that automatically will have a poor tongue posture, and secondly, you're going to have a child that will not be able to keep this appliance in their mouth at night, which is important because that's when growth hormones are released, and it's a postural component we're trying to change. But these kids have worn the appliance well, are breathing through their nose, are doing their tongue exercises, have their build-ups on their posterior teeth to eliminate the initial point of contact so you don't get that functional shift. Just tremendous results. Parents are always impressed because they see the kid come in with this really pronounced bulldog-type bite, with simple treatment. And I always tell them this is not guaranteed. You may need further treatment later, but at least it's going to stop the jaw from getting worse. And these patients are ever so grateful when they see that their kids' 4 incisors have erupted over the lowers as opposed to under as they were heading. And here we're seeing many of these cases using the Y3 appliance developed by Yani Sawa in Japan, and a little bit of early treatment. Remember, it's ideal for postural cases. If I have a non-postural case that is maxillary deficient, I'll use an expander in the upper, but with a reverse pull face mask. So then you're talking about a little bit more elaborate treatment. But these young little kids, and they're between 4 and 5, 6 years old, and they don't have maxillary deficiency, you don't want to give them a maxillary deficiency by continuing to allow that mandible to hit the crossbite and be postured forward. Slightly older child here, but again, amazing orthopedic results. And this makes the fixed appliance therapy, if it's required, much easier and more stable. Why? You're not fighting the overactive muscles, you're not fighting the poor tongue posture, and this is the real exciting phase of treatment for me when it comes to treating these young kids. And this is more of a unilateral crossbite. Child has a crossbite only on one side, but still promoting the mandible to posture forward, but then deviate to that side. And again, build-ups to prevent that initial contact, done indirectly with a appliance technique and a YC3 appliance. The problem we have when the kid presents with these pseudo-3s is a compression of that upper lip due to the postural imbalance of the lower. And the second thing we see is the disharmony of those muscles off the lip. So you don't have a good lip seal, and what you do have is the pressure of the upper lip on the maxilla. By putting in one of these trainer appliances, you can see that you're converting that hypermentalis activity into more forward growth of the maxilla. And the last thing, of course, relates to the lower tongue position. You can see we give the children exercises that encourages their tongue to go up on the palate. If you ever have the opportunity to come and listen to one of my more formal seminars, I do a whole component on oral myology using a system developed in Barcelona by Professor von Buren, and that is called the MFS system, where we take the kids through these. Hello? Did we lose? Is that still on?
No, still on.
Still on? Good. Okay, I just got some background noise. Sorry. And you can see that the effects of the proper lip seal automatically change the position of the tongue. And I always say to parents, open your mouth and see where your tongue lies. And it lies down on the mandible. Close your mouth, get your lips together. Where do you feel the tongue? Up on the maxilla, where it should be. So this lowered lingual posture actually is very bad for the perioral muscles. And what we're seeing and what's described here in the book by Professor Moyers is the concept of getting that tongue from being sorry, something's going on here. Okay, I think that's back on. So what we are seeing here is in this before and after lateral sephometric radiograph of a class 3 patient, you can see the elevator effect of the tongue. So on the left-hand side is the before class 3 jaw pattern, and on the right-hand side is the after, correcting the cross-bite and then changing the tongue elevation. So the textbook on removable orthopedic appliances by Dr. Graver and Newman discusses in the section on class 3 treatment the incline occlusal plane effect. So what we're doing here is changing tongue posture so that we can use the tip of the tongue behind the upper incisors, the tongue hitting the maxilla, stimulating the width. So we've done the early work, we've eliminated the factors that are contributing to poor muscle tone. We may have done a lingual frenectomy, we may have improved nasal breathing. Now we've got to give the kids some exercises to keep the tongue up on the palate. And this comes to now what we call our retention appliances. And these really can be a Frankel, which is what I'm going to describe, or they can be a reverse bionator, or what's called a Truett 3 appliance. All these have very similar features. There's posterior occlusal coverage, so the upper and lower incisors are not in contact. That's equivalent of maintaining those composite buildups that Tanus had described. And then there's a screw, which is normally in the buccal pads of the appliance, which can be activated so that the upper teeth are always pushed forward. We don't use a labial bow as you would for a bionator because we don't actually want to restrict the forward movement of those incisor teeth, those maxillary incisor teeth. Here's just a simple version of that appliance, and you can see the kid would fit this in their mouth. The labial bow is actually on the mandible, using that as an anchor source. In the upper you have those parallel screws which you can activate with future growth, and it's basically bringing that segment forward. You can see here a child wearing one. When would I put one of these appliances is possibly after we've done the postural change, when we know the tongue's in a good position, and now we want something for the kid to wear at night to hold in that position. Different modifications of this. You can see here again, lower labial bow for anchorage. You can see a Y that we can bend behind the upper incisors, keep pushing them forward, and you can see those gears that are sort of giving us that continual maxillary protraction even without the benefit of a face mask. If it's a more severe case, and I've used semi-rapid expansion of the upper jaw in conjunction with a reversible face mask, then I will use this sort of holding appliance. This is called a Chewit 3, and you can see the upper component has the gears that can continue to develop the upper jaw. It has a lower component, which again is a labial bow, but a labial bow that allows the kid to put an elastic on. So you're getting some active force to this class 3 jaw pattern. So if you look at this appliance, you have a occlusal coverage component on the upper with hooks on the upper labial bow, so if need be the kid can still wear the face mask at night. But you add cribs on the maxillary first molar so you can run a class 3 elastic. So you're getting the best of both worlds here. An appliance that excludes upper and lower, so eliminates the crossbite, that continues to develop the upper, that allows face masks to be utilised and allows class 3 elastics to be worn. So it's a very, very clever design, and I would certainly use this in the more severe mid-face deficient class 3 kids rather than the simple postural class 3 kids where I'd use that modified Hahn or upside down bionator or Frankel type appliance. The only thing you need here is enough teeth for retention. And that's why I tend to use this in the late mixed dentition. And you've got to make sure that if you have any anterior spacing in your upper jaw, you close it either by cosmetic bonding, so that, as I've shown you, you make those baby teeth bigger to maintain the space with the adult teeth. What you never do is close up that spacing that's occurred because of arch expansion by using something silly like power chain that's going to then de-torque your incisors and push them back into a class 3 overjet. So maxillary retrusion, and this comes from Rob Frankel's classical paper published in 1980 in the British Journal of Orthodontics. Here he's showing the muscular imbalance where in maxillary retrusion and mandibular protrusion there's a reverse postural imbalance, and that's what we're trying to break with our appliances. And what Frankel went on to say is that with these vestibular shields, they stand away from the maxilla, but they lie close to the mandible. So what they're really doing is stimulating maxillary development and using the mandible as anchorage to do that, which has some form of reciprocal restricting effect on that jaw. So in that way, if you understand Melvin Moss's theory of growth and development, the functional matrix theory, in that way a soft tissue capsule that's encircling the maxilla is expanded and you get considerable tension at the sulci, which is producing that forward growth of a point. And those structural and I guess you can call them functional disproportions that you saw in the previous diagram can be eliminated, and that's a very good way to stabilize what you've done. So this is a Frankel appliance, and obviously they're a lot more bulky than the Chewit 3 or the Hahn, but they work well because if I show you with my arrow, you've got the buccal shields that are keeping the bucks nutter away so the maxilla is not being constricted. You've got an appliance component where the tongue is pushed up on the palate, but there's no acrylic in that palate. You've got these palots which keep the upper lip at bay, and as a result stimulate the forward movement of that maxilla. Remember though, you want to ensure that the child is a nasal breather at this stage, because if they're a mouth breather and they have an altered mandibular posture, particularly those in large tonsils, as we discussed earlier, it may produce that protruded mandibular posture, which causes the backward rotation. So those alterations in mandibular posture are really not a good thing in these class 3 patients. What you're trying to encourage in these class 3 patients is the tongue to have oral volume, for the tongue to go from the lower jaw to the upper jaw, and for the shields of the appliance to keep the cheeks away and keep the upper lip away so you get forward growth. And you can see this appliance, remember, is worn as a nighttime retainer. When is it worn? It's worn after I've done early treatment on these class 3 jaws. What early treatment have we done? The sort of stuff I've described, which is the planus direct tract or indirect tract buildups, the YC3, IC3 myofunctional trainers, the semi-rapid expansion of the upper jaw with the reverse face mask, be it a Hickam type face mask or the newer Tandem bows. And this modified FR3 has all the benchmarks of a good retainer for class 3. It has occlusal coverage between the posterior segments. It has the sagittal screws in the upper pads. You take your wax bite in the most retruded position of the mandible, so you have the labial bow acting as your anchor in the lower, but you have a propulsion bow behind the upper incisors, so you can activate that and you can push those upper incisors forward. On average, a kid wears this for about a year, and we see very, very good changes in face and tongue posture, in eruption of the teeth. When you start seeing that further growth of the lower jaw, which of course you will in these class 3 kids, you can then start doing activation by grinding the maxillary occlusal coverage flat, and then by starting the tuning of those expansion screws once a month. So that's giving you the activation of propulsion bow, which is behind the upper teeth. So at any time you see that initial anterior crossbite that you eliminated, maybe tipping to an edge-to-edge, slipping back to a crossbite, you want to get in before you slip into crossbite. So when we fit these, we have no activation for the first 3 months, and then depending on growth of the jaw, depending on the posture, depending on the crossbite tendency, you'll start adjusting the gears. And I normally see the patient sort of every 2 months to keep an eye on things. So here's a modified Frankel 3, and just putting my arrow on the different components, sagittal gear to drive that upper lip away and to allow the incisors to come forward. Behind that, which you can't see in this diagram, is that propulsion bow. You have a lower labial bow because you want the anchorage there. You have these big cheek pads or buccal pads helping that intraoral space that we've discussed from Frankel's research. So sort of right onto that hour now, which is all I wanted to spend on this, but it's such an important topic. What do you do when you have kids that are class 3? Check mandibular posture, see if you can eliminate that anterior crossbite. Many times that involves shaving down the deciduous cuspid and some occlusal coverage and or composite resin. Then check if your maxilla is retrognathid, because if your maxilla is retrognathid, you've got to get in early to get that maxilla forward. The maxilla comes forward with some semi-rapid expansion and a face mask, or some semi-rapid expansion and a vestibular appliance. And before you do any of those orthopedics, you want to check for an enlarged lingual frenum, check for large tonsils, and basically see where the tongue is resting. And I guarantee you, these class 3 kids have this postural imbalance where their tongue is always resting downward and forward. And what you've got to do is get them breathing through their nose and change their tongue posture from being downward and forward to being upward. And that's where those IC3s and those YC3 appliances work so well. And I just basically keep the kid on a holding pattern, seeing them on a yearly basis till they get their adult teeth. Now, as I said, I'm happy to send you this entire PowerPoint as well as the references, but I'd really like you to see that so much research has been done in this field to point towards the benefits, clear benefits of early class 3 correction in at least 80% of kids. So my email again, info@myname, info@derekmoney.com. If we don't have time today to answer questions, you can just email me. I'm happy to answer them. And repeat of this lecture will stay up on the eDent website, plus link through to my Facebook and YouTube. I put up possibly one lecture a month on YouTube, all to do with early treatment in orthodontics. I'm very passionate about that. So if you like what I have to say and you want to learn more, please follow me on the YouTube channel. And with that, I think if I can hand back to the moderator.